Right, I will start there. I want to just say thank you to everyone for joining us today for what is lining up to be a really interesting webinar. For those of you that attended our last webinar back in October, thank you for coming back. I'm hoping that means you enjoyed the first one. For those of you that are joining for the first time, thank you for taking the time out of your day. I hope you enjoy what we've got in store for you for the next hour and a bit. So I wanted to kick this off with a few thoughts of my own. Firstly, for the most obvious question, why now? Why are we running this webinar on this day? Because of course the 10-year plan came out back in the summer, so why have we waited 6 odd months to actually do this webinar? And no, it's not because it's December and we assume people would rather come and do this than wind down for Christmas or work. We have put it now because we think we've reached a point where the plan's been out for long enough that we can really read it and understand it and find out what that means for us individually and for the sector more widely. To give some context for this webinar, I feel I'd be doing it a disservice to not draw attention to the not insignificant issues that we as the healthcare sector are facing. Public Accounts Committee last month came out with their finding that the NHS is behind its overall target. They went as far as to suggest that the 18-week wait being reached by 2029 is looking somewhat unrealistic now, as well as also the huge workforce pressures. Royal College of Physicians, again last month, coming out with their report about the unrelenting pressures, as they're calling it, on the system, and about the growing levels of burnout that they're seeing. Now, that is, I'm aware, a pretty bleak prospect and not the most joyful way to start the webinar. But on the more cheerful side, the NHS, the 10-year plan, does promise a lot on how it's going to fix that. So to discuss that further, I'm joined by my wonderful panellists, who are Dr. Zoe Wyrko, who was formerly a consultant, geriatrician and medical director within the NHS, and is now the Wellbeing and Quality Director at Riverstone Living, as well as Chris Fleming, who is Public Digital Health and Care Sector Lead, with, it's safe to say, very extensive experience helping the NHS and other health organisations use digital technology, probably most notable for his work on the NHS app and 111's online service. Also, Darren Stapelberg, the CEO of Grosvenor Health and Social Care, Tom Fellows, the Head of Policy and Value Proposition at SpaMedica, and Jason Coombes, the Business Development Director for Mazik Global, who holds the commercial responsibility for client relationships within the EMEA region. So thank you all for joining me. Pleasure to have you here today. Without further ado, I'll start by asking some fairly general questions. I'll address all of you as a panel, just get your thoughts, get your opening gambits. I'll start by asking, the NHS 10-year plan places a lot of emphasis on the integration of care. What are we seeing as the likely barriers to the coordination between the acute, primary and the hospital services, and is there a straightforward way to overcome that? Any opening thoughts? Zoe, hey.
Thanks, Theo. I mean, it's a great question to start with, and the answer's really in your question to that one. So while we continue to look at acute, community, primary care as completely separate entities, and while they are funded as different entities and in different ways, there are always going to be barriers. And one of the biggest ways for breaking down the barriers is actually to make sure the funding is different and to make sure that the funding is where the person, the individual needs it to be, rather than where the organisation needs it to be. And that's how the barriers can start being broken down. But it's a huge thing. It's been spoken about for years and never actually happened. But that's something that could really help. And it's how can we sort of play roles in that, actually look at the system as a whole rather than as those separate sectors.
Brilliant, thank you. I agree entirely. Actually, the idea of breaking down barriers being the key one is huge. Chris, I'll turn to you.
Yeah, I just wanted to build on Zoe's points because I think she's absolutely nailed the most important thing almost straight off the bat. But I wanted to kind of provide a digital lens on some of that. So obviously, enabling integrated care will require providers to address various digital and data challenges. Most notably, like providing care cannot function effectively with that, longitudinal view of what's happening with a patient, spanning those different institutions. So there's an investment required in, shared care record infrastructure and data sharing and all these kind of things. But really at the heart of all that is relationships. And to be able to work in a coordinated way requires trust. Data sharing agreements require trust. Working together requires trust. And that trust and those ways of working, they take time. And so the kind of and this is where I want to link it back to Zoe's points on funding, as well as changing. Like, I think part of the aspect of funding that needs to change is to provide, if you like, longer term and more flexible ways of funding, so that system services can mature and teams can work together. The endless sort of cliff edge capital out the end of the financial year sort of cycles of funding can be really damaging for integrated partnership working and maturing these digital platforms that enable it. So I just wanted to build on Zoe's point there.
Really, really good. Thank you. Tom, you have something to add?
Yeah, in danger of sounding like a very well rehearsed start to this. The point that was raised about relationship building as well, I think is absolutely critical. I'm thinking back to 6th of January this year, which feels an awful long time ago, longer than most 12-month periods this year. It's been a lot of challenges this year. But on the 6th of January, the NHS England and the Independent Healthcare Providers Network launched a partnership model and agreement between NHS England and independent sector providers to collaborate, to work together and talk about planning, to talk about sharing experience, capabilities, and what works. A model that perhaps has been left a little bit on the shelf as lots of other things have taken priority this year. But the work that went into building that, I think, is still absolutely valid and is a critical part of how you build those relationships. And how you get the most out of the sector. And we're here to talk today about out of hospital care. I think what we mean by that is accessing care out of NHS trust hospitals and in all sorts of other different ways. And whilst that was a really helpful model, I think what we really need to do now is look at how do we implement that with local relationships with commissioners, with open discussion, and ideally with time to plan and talk about what's possible.
At risk of sounding like a very well rehearsed opening, I'm going to go on to our next question then and say, what areas are seeming like the most realistic opportunities to shift this patient activity outside of the hospital? We've talked a lot about how it's a good idea. Where do we see this as something that could happen? Are there areas where we realistically could make this, where we can really get our first steps into proper out-of-hospital care? Any thoughts on that? Okay, Zoe, hey.
I didn't want to come in first again, but so there's sort of there's more than two ways. There's obviously what elective procedures can happen in different ways away from the big shiny buildings. And then another way is looking particularly around older people living with frailty, which has been sort of my key area sort of throughout my career. It's firstly making sure that people only go into the hospital if they need to be in the hospital, either at the start of an acute illness or at the end of an acute illness. And those are sort of really big areas. There's been some phenomenal work done around hospital at home services. They're sometimes referred to by NHS England as virtual wards, but hospital at home is a much more accurate way to describe it, because people aren't being abandoned in their own homes with just a monitor and a nurse popping in, once a day. It's so much more than that. And I think that's a really big area to focus on. And because so much can be done. But to get that to work, you need public acceptance of it. So they need to understand that they're not being shortchanged by not being in the big shiny building. And you also need acceptance again, and this is where it's back to the communication, the systems, the staff and colleagues working within those services. It might be completely different, but it's actually how can we have everybody working together, communicating, feel that their voices are heard, because that hospital at home, could play a really big role, particularly for the people that I'm most concerned with.
Brilliant, thank you. Chris, I'll go to you next.
I think Darren had his hands up, and I've already spoken. So Darren, I don't know if you want to come in first, and I can.
No problems at all. I think Zoe covered the point there. I think there's two magic words that have come out in the last few minutes from both Chris and Zoe, and it's trust and acceptance. I think it's the trust that the not just the private market, but the part that social care plays in the NHS 10-year plan. I think that's the part that's often being missed. It is about communication, it is about trust. But I think it starts with acceptance. Who's it? What part is being accepted from the NHS, from the healthcare and social care, and the parts they play? Because after that, we can then build on. Absolutely right. It's communication of the patient pathway, communication of roles and responsibilities, and accepting who's got those sharing of ownership and responsibilities. Then we can talk about the sharing of the money, i.e. Zoe's key point. The funding is ultimately going to be one of the biggest barriers, but it's not a barrier that can't be overcome when there is that trust and acceptance of the part that everyone plays in, where ultimately is the centering on the patient's experience and the patient's pathway, which is ultimately going to save the NHS in the long run.
That makes it that builds very nicely. Tom, I'll go to you now. Just aware.
Sure. Okay. I think the 10-year health plan. The three core initiatives, when I look at it, are all about moving activity out of the physical NHS trust buildings. Either into virtual digital services, into community settings, or into prevention. Stopping people ending up in hospitals. So I think that those are it's a noble purpose, isn't it? But how you deliver that is still really difficult. I do think that there's this point about the money. Everybody wants to talk about the money, and everything is clearly enabled by money and funding. But I think we also, from our perspective, certainly from the provider side, in the independent sector provider side of things, we need to think about value. We need to think about the solutions that we offer to the NHS's problems, which are sometimes different to what we perceive them to be. So I think that we need to kind of put ourselves in their shoes and think, well, how do we deliver value that might secure some of that funding, or might make that funding easier to spend from their perspective? But how do we do that in a way that addresses the problems that the NHS has? And later on, when I talk specifically about the ophthalmology sector, I think we're certainly looking into some of that at the moment.
Brilliant, thank you. And Chris, I'll go to you now.
Thanks, Theo. Yeah, just on the opportunity areas, I wanted to mention outpatients. So, like, the way outpatients works, is pretty inefficient and clunky. People getting lost, people coming in for routine appointments just to check in, lots of incorrect letters going out, broken things, etc. Some of that is digital and technology's fault, but not all of it. It's really, again, about an operating model question, like how are we running these services? I think there's a lot to learn, and these kind of inspired by conversations with the Royal College of Physicians. I think there's a lot to learn here from the reform of primary care, who I think are now at 50% have moved to this sort of total triage model. So taking away the appointment slot as the de facto kind of quanta of activity and moving to a model where you are directing people to, maybe they just need a phone call, maybe they just need an email with a test result, maybe they don't need some self-care advice. So, opening up that line of communications between the patient and the practice, you can deal with things differently, and reduce that need for kind of routine appointments that exist almost only to prevent patients getting lost in the system. So I would say outpatients is my area.
Thank you. And something we've touched on a couple of times already, the funding and the commissioning. So I'll ask a fairly broad one on it to get your thoughts. What do we, as the panel, believe is the best way for commissioning models to evolve, so that we can properly incentivise out-of-hospital healthcare? Could it be a move to integrate budgets between the NHS and local authorities to force the hand, or is that too heavy-handed? Is there a middle ground? Darren, yes.
So I'm trying not to laugh there, Theo.
I thought you might be.
Budgets and integration has probably been around longer than the 27 years I've been in health and social care. So we've been talking about integrated budgets and PCTs and JCBs and RCBs, for the last 27 years. But ultimately, yes, it is that. What are we going to do to force the hand? Because ultimately, that's what it comes down to. And I think it links back into the commissioning models are out there. There have been some really innovative ways of commissioning, both at an NHS level as well as a local authority level on the social care side, to ensure the integration does work. And there is a client and patient pathway through the service. Ultimately, it comes down to the trust for that to work. We go through lengthy documents of bidding on NHS trusts, on NHS trust contracts or local authority contracts for ultimately the same achievements. What you then find later down the line, once you get into these pilots and you get into the contracting terms, is that actually the commissioning model that was set up doesn't have buy-in from every side, whether it be financial, whether it be responsibilities, whether it be ownership. So I think the simple thing that we can do to actually make that move, the commissioning models, is actually trust the bidding process, trust the setup. And that comes from a original contract being driven with input from every party. The amount of contracts we have, we work with 38 local authority, 38 RCBs, the amount of contracts that you can read and tell straight away whether it's a health directive contract, whether it's a social care directive contract, whether it's our patients directive, to pick up Chris's points. And there's a lot of contracts we look at now. You can see who's been the lead in building their contract. So from a commissioning point of view, it's simply around getting back to that trust and acceptance that there's a patient pathway at every single point in this NHS pathway that everyone has to play a part in, and let's trust the process as we build that commissioning model for them.
Thank you. I think I agree in general. Yes, Tom, I'll turn to you.
Yeah, thanks. I think there's also I'm often torn between kind of how the system was designed and how it actually works as well. I think that some of the core principles, or what I think of as core principles of the NHS around patient choice, around payment by results, PBR, the money follows the patient. I think some of those principles are at risk in order to ensure that the financial balance that NHS England are striving harder than ever to achieve at the moment. I think some of those principles are at risk at the moment. Tying up funding in block contracts with trust is still very much a challenge that faces some of the flexibility that you might want in commissioning models. I totally understand why you do that, because there's a huge amount of risk involved in not doing that. How do you price for risk in the system? But some of these areas where funding gets tied up, I think do need to be challenged, and I know that NHS England are trying to address that with aligned payments incentives and then flexible elements of funding. Some of those are really difficult problems for the NHS to resolve. But if you can address that, if you can kind of really create that trust in the system to support patient choice and to support the activity moving around the system in a what we might think of as a free market way, then I think what you get in the return for that is the best value. Patients treated in the right place at the right time and delivering the best outcomes for that activity. And it probably plays into those other downstream activities as well, particularly around prevention. Prevention is the investment that needs to be made today that won't pay off until 10 years down the line. But true prevention, I'm thinking weight loss and reducing long-term condition from appearing down the line as well. So there's a lot of problems with money, but there isn't enough of it. This is the wicked problem facing the NHS.
Thank you. With that, I'm going to move on to some more slightly targeted questions that are prepared. And Tom, I'm actually going to call on you straight away again, having just finished your answer there. And I'm going to ask, with elective recovery having relied so heavily on independent sector capability, what lessons from ophthalmology can be applied to other specialties across the board to accelerate the way that we're delivering out of hospital care at the elective level?
I think we're rightly proud of the role that we've played across SpaMedica and our colleagues in the independent sector, particularly in the ophthalmology sector, arguably, but it's the biggest success story in post-COVID elective recovery. Waiting times for ophthalmology in general, I know everyone will be thinking, yes, that's cataracts, but in general, waiting times are lower than they were in January 2020. So that investment into community hospitals and the provision of services has absolutely been critical in helping the NHS in that elective recovery story. So I think that there are a number of elements within that actually can be shared across other specialties. But there's also a few that are quite unique to ophthalmology. The one thing that I think that we've focused on very heavily at SpaMedica is our relationship with the community, with community providers. And in ophthalmology, that's high street optometry, opticians that identify, diagnose, manage a lot of conditions, and then refer in to specialist providers for elective surgery, such as ourselves. So I think that model of community optometry and secondary ophthalmology providers is unique to ophthalmology, but actually has worked really well. And we send a lot of patients back into the community for post-ops. So we're not running post-ops in hospitals, we're doing them back in the community in the majority of cases. I think the other thing that we've done at SpaMedica and taken a leading role on, and one which I was very pleased to be in receipt of the LaingBuisson award for a couple of weeks ago around excellence in training, is that training focus. So we do more surgeon training than any other provider. We've got 160 surgeon trainees across our 64 hospitals at the moment on a cycle, and that's a critical part of supporting the problems the NHS has. A few years ago, the influx of investment into community ophthalmology providers was seen as a challenge, a problem, and what would happen to training opportunities. We stood up to that problem. We've, as I say, got a lot of training opportunities now for surgeons and medical students and others as well. And we're trying to be part of those solutions to the problems that the NHS might have around creating those opportunities. Not only that, but it also allows those surgeons to learn about high volume treatments, managing high volume lists of cataract surgery, really high efficiency best practice pathways. And that's the offer that we make back to the NHS. How can you share in what works, what drives brilliant outcomes, what drives great patient experience, and does so in a way that is at the price the NHS sets. This is the value offer that we have at the moment, and I think something that we're incredibly proud of our role in that success story.
Thank you, Chris. I'm going to come to you now. And something that has come up several times is the idea of digital transformation. That is one of the key pillars. But digital transformation as a concept is quite often slowed down by legacy systems. What are the most meaningful changes that we could make from that digital point of view that the NHS could sort of realistically implement in the next, say, 2 to 3 years to support this out-of-hospital healthcare?
It's a great question, this, and I think it's a tough question. 2 to 3 years, thinking about kind of national scale, that tends to be when things are really just starting to get going. When I worked on as you mentioned in your intro remarks, Theo, I worked on rolling out the digital channel for 111. Also helped launch the NHS app. NHS app is a good example. When I handed over responsibility for the NHS app in the pandemic, because moved on to other sort of kind of urgent digital platform delivery stuff. And as my leaving gift from the team, they bought me a mug with the NHS app logo on it, and it had a strapline underneath that said, "Your practice won't have heard of it." Because at that time, there was, I don't know, we had 1 million registered users, maybe. Of course, pandemic happens, COVID pass, and now the app is, 34 million registered users. there were 6 million prescription events in October alone, and 17 million logins. So, but that's like we're 5 years down the track now to get that sort of level of maturity. And that delay is precisely because we are in a very, very brownfield environment, as you describe, a lot of legacy. For interoperability, at local level, it takes time. It's not just the technology, it's bringing people together to agree standards, to agree, the meaning of particular kind of, data and informatics. So I'm going to answer this question by saying, like, for that shorter time horizon, the place I would start with is actually trying to work with the technology you have to redesign and rethink your operating model and processes. A lot of the things you'll be working with already that you have are configurable. A lot of the processes that are in place are just because that's the way we've always done it around here. They can be torn up, they can be changed. More so than you probably accept, and you will learn so much about your users' needs, both your staff needs and your patient needs and your requirements, and you will also, in doing that, build that coalition and trust that is required for integrated care working. So I would say, like, we define digital as the culture, operating models, processes and technologies of the internet era to help respond to people's raised expectations. And so focusing on those, the non-technology aspects, I think are where there are some real wins.
Okay. And to follow on that, because we were talking about the ways digital can be enhanced and then accepted, can we be sure that digital solutions are going to improve the workflow rather than just making it another administrative task for staff?
Now, this is a really good question. This is a subject really close to my heart. So when I've worked on digital products and services, it's really, really important to include the concept of user-centered design. So people who are expert in how people interact with computers, with apps, designers that can help design good content, can design good interactions on the screen. When you pick up your phone, all of the apps that you use every day have had a lot of user-centered design. So you don't need training in them. They just work. And actually, when they don't work, you really notice that. And those are you can start to identify, okay, this certainly hasn't had a designer look at this at any point to make it a good user experience. So I think both in terms of the design of products, developed and owned by the NHS, but also those developed by the vendor market, making sure we're expecting particular standards of usability and user-centered design. And in doing that, that's how you can make sure that it's not adding burden, adding extra unnecessary clicks, and is a more efficient and effective experience for staff. So that would be my answer. Injecting the notion of design, which is actually quite. I've worked with a lot of trusts, and the amount of design capability that sit in providers is very low, and that service design capability is also really helpful for rethinking processes and operating models. And in the vendor space, in the software vendor space, it's patchy. I'll give one example before I sort of hand back to you, Theo, which is I'm sure many people on the call will know Accurex. They do software for primary care, specifically triage and patient messaging. I've got no vested interest in Accurex, but it's a good story about how they used usability to help them scale and sell more of their product, which is on their website, they allowed users of their product, so GPs, to go on and type in their phone number and send dummy messages to their own phone. So literally, the GPs who are maybe thinking of onboarding with that were able to try before they buy and just test what the messages looked like coming to their own phone. And that alone built such trust in, they could see instantly how usable and how, how effective that would be for their practices, that really helped them kind of scale that business. So I'll just leave you with that example.
Brilliant. Thank you. Jason, I'm going to come to you now, and effectively building on what Chris said about adapting this new technology. How can specifically ICBs, but generally providers, ensure we have some level of interoperability when we see that so often different trusts are at different levels of digital maturity? Some have newer systems, some have old systems. How can we make sure we're all on the same page?
Sure, and this is actually a really big question. And before I start, let me just chime into what Chris has just said, that um, adding to his point, the involvement of the key users in any development of any app or any technology is fundamentally important. And I think if you don't have that early engagement, that early involvement in any design, then you're not going to have a successful rollout. You're not going to have a successful adoption. And any technology is only as successful as its adoption allows. But in terms of interoperability, when we talk about interoperability by trusts, we shouldn't begin with standards or technology, but instead with clarity on shared goals and objectives. So before setting guardrails, we've got to first understand what the system is trying to achieve horizontally across all providers. Interoperability becomes achievable when ICBs start with horizontal alignment, agreeing on what information needs to flow, what processes must be consistent, and what outcomes matter across the whole system. And once you set these goals, you can then define the vertical enablers, standards like FHIR, API guardrails, information government rules, shared platforms such as Sharecare, Record, Dataverse, and Entra ID become important. And the key is not forcing every trust or every partner to reach the same maturity level, but building a common architecture that allows each organization, even those with older legacy systems, to plug in. And we see things like low-code tools, modular extensions, which can quickly uplift providers without expensive sort of EPR technology replacement. And we've seen this work in practice in our sort of healthcare. In the home environment projects, we've connected NHS referrals, pharmacies, labs, nursing teams, and logistic organizations, all with different digital baselines into a single flow, in our case, using Microsoft Cloud. And I think that's exactly the model that ICBs can adopt to align on goals, unify the data foundation, which I think is something that Chris mentioned earlier about that data being absolutely fundamental, and then let every provider contribute at their own pace.
Brilliant. Thank you. And to build on that, you touched on it pretty earlier. Are there specific ones to call out as the most effective digital tools for coordinating discharge and reducing the length of stays in hospitals? Are there any you can point to and say this is it? And if so, how can these integrate?
So we know from our work, and we talk to a lot of NHS CIOs, and we know that discharge, along with admissions, is amongst the biggest challenges that they face, that are to some extent out of their control. They can't control the numbers that are coming into the hospital, and they often are events that are outside of their control that control how patients are discharged. And we've seen that the biggest improvements come from closing the operational gaps that sit between teams. So, for example, the wards, the pharmacies, the estate transport, the social care, and then the aftercare providers in the community. And our experience is that today, many of those teams work in isolation. And we found that low-code power apps, workflow automation can potentially fill those gaps. The gaps of bed turnover notifications, transport requests, pharmacy to ward updates, and social care readiness alerts can be impacted. And these tools kind of link directly into existing systems, and they give a real-time view of patient flow, which is fundamental. We've seen, again, from our experience in home care, the coordination of nursing visits, infusion delivery, pharmacy distribution, that discharge doesn't just end at the hospital door, and the digital coordination that we've run in the home environment is directly applicable to supporting safer and faster discharges. And as we move down the line, agentic AI will enhance this further, but only when trusts have the right data foundations. So with proper data, with Dataverse or Microsoft Fabric in place, AI agents can orchestrate tasks, highlight discharge blockers, and support teams 24/7. But the foundation of that data has to come first.
Brilliant, thank you. Darren, I'm going to go to you because I want to ask a question that sort of builds on what Jason was just saying. Specifically, how can patient records and the digitalisation of these records alleviate the need for multidisciplinary teams to each have their own assessments and care plans and their own processes?
Yeah, thanks. I think Jason knocked the sort of nail on the head there in many ways. It's about getting away from working in silos. You mentioned the CIOs are working as a digital platform. I think what's quite clear is in many ways the solutions are out there. It's having the ability and understanding of the part that each individual plays in that, whether it be the community, whether it be the discharge teams. I mean, even within a NHS setting, we talk about sort of trying to integrate health and social care in the community of the NHS. Inside an NHS hospital, integration of services and a client pathway just within the physical building is something that leaves a lot to be admired in many of the RCBs and trusts. So I think it's almost stripping it back, and the solution in many ways, whether it be technical technology or individual sort of care services in the community, starts with actually understanding what the problem is and what are we trying to address, and ultimately who are we trying to address it to. And very often, a lot of the solutions that have been put in, whether it be community services, whether it be in the NHS trust, the solution is about a small silo or individual ward sisters in the old days, or a discharge nurse's absolute view of things, as opposed to the understanding the client pathway and essentially the patient experience is ultimately what we're trying to address. That then relates to the pathway, the journey, the services, and ultimately the biggest talking point, which you're always trying to avoid in many ways, the funding of that pathway. I think if we look at specifically sort of Grosvenor and the 7 providers we have up and down the country, SpaMedica, the main provider in the West Midlands, actually been working with an RCB and specifically 6 of the NHS, what used to be trusts and individual hospitals at the moment now, on exactly that, a quick discharge service to allow the patient journey to be sped along, but more importantly, serviced and dare I say, outcome-focused care. And we've lost that word in many ways over the last few years, and it's been a rhetoric word that's been around the system for a very long time. But ultimately, it can be done. And the quick discharge service has evolved over the last 12 years from a small pilot of 10 service users and mapping their service and their journey throughout the NHS and social care journey. But ultimately, what it came down to was addressing the key fundamentals. And that's how do we ensure the best patient pathway at the most cost-effective way that actually allows full integration of all the services, be service delivery as well as financial metrics within those. It's been really successful in many ways, and I think the solutions and very much are technology based. There are buying in, it's trust, it's relationships, all those things built in together. So solutions are out there, and unfortunately, what we see very often is the wider understanding, the part you play in that small journey is often lost. The digital pathway and digital records absolutely fundamentally changed our whole pilot within this one RCB workers, because we've got previous and future planning of the need that ward's going to have. We have an idea of the current sort of passage of service users and residents going into their pathway, whether it be community-based service users, whether it be residents in a care home that are going back to a care home. We've got forward view of what that's going to look like. So from commissioning points of view, it's really easy for the local authority and the NHS to commission a contract that says, we expect X amounts of volume of traffic coming through. Have you got the capacity as a community-based provider of mainly LD services, without sort of breaking them all down? And yes, that's about trust. So we're trusting Darren and SpaMedica with the ability of, here's a list of 450 potential discharges this week. Of those 450, we expect X to be out within the first 2-3 days. Have you got capacity to pick them up? So, but that's very early planning. And I'll use the word trust quite a lot, because that's information that you won't share outside of the ward, never mind outside of the NHS system, then outside into the social care system. So I think ultimately, the changes and part of the solution is that digital record, is that digital pathway. We've got forward planning of a service user going into hospital, might be an outpatient, might be a specific, might be purely just the rehab services. But we know their expected discharge date is X. We can start planning for that. We're not getting a phone call as we used to in the good old days, as we say. Patient ready to come out. Can you deliver a home care package? Physically not possible. You can't just create capacity in the market. Through working with the NHS, working with the local authority, how do we pre-plan that? And it is a case of trust. So we are block contracts for a large number of hours to deliver quick discharge service from that area. But with that, it comes trust. There are weeks where we go way over and weeks where we go under. We average 480 discharges out of 4 hospitals in one location every single week, and delivering over 38,000 visits to patients who would have been in hospital in that 1 week, and that's every single week. It's taken 12 years building it, but a lot of it comes down to the invention of the digital record. Absolutely helps. We're not doing 5 assessments. We did this mapping going back to 2012. Every individual being discharged out of hospital within the first 24 hours of being either at home or in a care home received 5 different visits into different assessments within 24 hours of discharge. Now, not only is that inefficient, let's go back to the residents and the service users and the patient pathway. That's absolutely not efficient in any way. More importantly, it's not helping the recovery process and things like that. So I think it's been really, really interesting seeing how that's been built into it. So it is about trust. We now have one patient discharge form that is shared throughout that NHS, as well as discharge teams, as well as the community providers, not just ourselves, but us as a contractor provider. There's 3 contractor providers that have access to that record and that assessment. And everyone accessing that record or doing an assessment is trusted to be the right individual. Zoe touched earlier on virtual wards. It's very much exactly that. It's a multidisciplinary team. So it may just be a care worker, or it may be what used to be a district nurse, at an early intervention service or a discharge service. But everyone is trusted because everyone knows the part they play in that record, in that assessment of that individual. And it's saved, instead of 5 visits, it's saved 1 visit. 1 visit after discharge. We do the quick discharge, the service is delivered, and that individual may have 1 hour of care. They may have 6 weeks worth of care and they go into long-term package of care. But that same record, that same assessment has gone from 5 people visiting within the first 24 hours to 1 visit who also delivers the service, and everyone trusts and buys into that. So it's been really, really interesting how the trust and acceptance of the part everyone plays, together with a mechanism, i.e. that digital record, that digital assessment, has really increased not just the efficiencies and those the one trust and one ICB reports 147 million pound saving on that one individual over the last 12 months, one individual change, which was the quick discharge service.
Fantastic. Thank you for answering that in such detail. Brilliant. Thank you. Chris, I see you've got your hand up. Do you have something to add?
Yeah, just a very quick thing to add. I really enjoyed listening to kind of Darren's description there. It was really insightful. I just want to make a comment on how the system dynamics flow into the technology. So the Professional Record Standards Bureau did a report in 2003 that looked at the information record standard for e-discharge. So quite a lot of investment has gone into sort of standards for transfers of care information, but it's got really low uptake. And basically the reason for that is secondary care providers or their IT system providers do not really see the value in changing their, in prioritizing those changes because the benefits are felt elsewhere. So that is an interoperability standard that is not, being as implemented as widely. And if it was, it would be much better because you'd have sort of, structured data, be able to integrate into workflows. People get, better information rather than sort of inconsistent PDFs that are impossible to find, etc. And I know that's not the case everywhere, but I just thought that was an interesting example of how the wider dynamics can impact the tech.
I think just throw on there. Chris is absolutely right. And just by a quick way of numbers, we work with 97 local authorities, 38 ICBs. We have 1 where we've agreed a partnership and a flow of information. So just to give you a idea of scale, so, across the country, 7,500 staff, as I say, 38 ICBs, and we have 1 ICB and 1 hospital group. I'm not even going to say trust because not even the whole trust. And although we don't use the word trust anymore, we have 1 hospital group, which is 2 hospitals linked together, where we managed to agree it and actually prove, not just proof of concept, but it absolutely works. We cannot get the same thing rolled out into any one of the other 37.
Thank you for that. That was brilliant. Zoe, I'm going to come to you now and almost go full circle. We've talked about how to discharge people best, but is there anything specific evidence-wise that you can point to about housing-led models or other ways that we can reduce the demand on emergency services and social care services and the requirement for hospital? Thoughts on that?
Yeah, absolutely. Thanks, Theo. So when I was on the other side, so working, much more directly in healthcare at the front door of the hospital, and on my delayed transfer of care service, generally everybody in health forgets about housing until somebody can't go home because their housing isn't appropriate. And housing we're out here going, don't forget about us. And if somebody's living in the right house for their needs, that can prevent frailty, it can prevent declines. If they haven't got, most of my clinical work was based in South Birmingham. So an area with, quite large amounts of deprivation, where it's standard to have steps inside your house, and also not unusual to still have an outside toilet. So, just little things like that. So being in the right house for you, the right flat for you at the right time, can really in itself just prevent problems that are the sort of thing that start catapulting people into acute care, even if that's what they need, and producing that, that sort of vicious cycle that we're all, and particularly Darren with Severcare, very, very familiar with. Then there's actually what sort of enhanced housing can you have? And again, this is, predominantly older people, but actually anybody who's got, any additional needs. And that's where having some type of support on site with that housing can really start to make an impact. Doesn't need to be somebody there 24 hours a day, but it's where you can have access to things, because actually you've got a concentration of people who can benefit from a service together. So that makes it easy to deliver it. It's very much rooted in a community because people tend to live where they've always lived, so they've got those roots. And there's some really interesting research. It's a few years old now, and it was done by the University of Aston together with Extra Care Charitable Trust. And they're an integrated retirement community provider, similar to Riverstone. And the thing that they have is a role called a Wellbeing nurse. And they do have fitness equipment on site, so it's easy to use the gym. And you have a sense of community because you've got other people there. When I say basic, in that straightforward, not complicated sort of questions that the nurses would run through with people when they move into an extra care village, then allows sort of conversation support to happen. And a whole lot of research looking at the quality of life of older adults living at extra care. So what are the things that might matter to them? They found they were happier, less isolated, lower levels of depression, lower levels of frailty. Then where you're coming on to looking at how does this impact the health and social care, lower numbers of falls. Now, falls are not inevitable with ageing. They can be prevented. And that's a big it's a big public health message that needs to get out there. But just by moving more, having advice on site, people fell less, so you had fewer acute admissions. Also reduced demands on the local general practices. So often GPs can be really worried if a new care home, if a retirement community opens up on their patch, because the immediate thought is, I'm going to have 200 extra older people without any extra resource to help support that. But by having somebody on site that residents can go to, they actually found that the number of GP appointments was reduced. And then looking at when the older adults needed to go into hospital, they found that they were less likely to need an acute hospital admission. And they also found that most of their admissions were in that genuine acute time frame. So you're looking at, 24 hours to 3 days. Hardly any of the longer 2-week plus admissions. So those only really occurred when somebody had a medical problem where they needed to be in the hospital for that long, whether that was receiving treatment, whether receiving rehabilitation afterwards. And that's actually, life-changing, both for the older adults it affects. It's incredibly satisfying to staff involved in delivering those services. And the impact on health and social care, if you extrapolate those numbers up, could be phenomenal. What can we do about it? So, we've thought about what partnerships with ICBs and housing providers. ICBs need to know about housing providers, need to understand them, need to know what a vital part of their network they actually are, and that in a lot of cases, there's a really untapped resource there, which would give everybody involved quick wins. In terms of records, ICBs, because we're not CQC regulated, don't use sort of note systems or those tech. Wouldn't link in that way. It's very much what the GPs, the community nurses who look after those residents, but then can have additional information provided by the team on site. So yeah, it's a really huge untapped resource that just isn't understood either by people who that sort of housing would be suitable for, or by the systems. When people ask me what's the biggest difference between what I used to do and what I do now, it's I used to watch the wheels falling off. I'd have somebody come in front of me, and I just had to pick up the pieces, once everything had gone wrong. But actually, I'd probably seen that person, or my team had seen that person in A&E, 6-10 times over the last year. No fault of them, no fault of their GP, just the way that they were accessing healthcare. And we'd have thought, well, if we could put care in there, if we could do that, if we get psychologists, if we could get physio quickly, we'd have been able to stop this. What I'm able to do now is support the older adults who live at Riverstone, and the work that my team's working on the ground do to actually prevent those declines. And it's that, true prevention that can really have a huge impact. Then you also, as I touched on before, it's about having the operators of whatever type of housing people are in comfortable with having their residents coming home at maybe a level that they might feel a little bit uncomfortable with. They might think, well, they need to be in. And that's where, going back to that being part of the community system, so that, the manager or the site manager of the housing block understands that actually the support they have, where they fit in the system, that they're a key part of that system, and that's, can make a huge difference. I also want to say it's really interesting listening to Darren talk, because I got quite excited when we did the pre-call for this, because I could see a Sevacare sign behind Darren's head, and Sevacare coming in and working with us with the integration work we were doing in Birmingham was one of the things that just changed what I was able to offer for my patients, like that, knowing that somebody could come into A&E, actually we could get them out. We could call Sevacare, have that one assessment. And I just so Darren's talked about the importance of cutting down the number of assessments. It's also having the assessment done in the right place for the person. Absolutely no point doing an assessment for somebody on a hospital ward. That is meaningless. It's not real. It's a false environment for everybody. How you actually make that assessment meaningful is by doing it once and well, but also doing it in the right place for that person, which is all about getting them into their own environment as quickly as possible.
Brilliant. Thank you very much for that. We'll move on now to the Q&A section. Obviously, I've been asking all of the questions, and it's been me and my team that have put these together. I've been seeing them tick up in the background as we've all been talking. So we'll go now to some more audience-led questions. When we put the registrations out for this, we also asked that if people had any questions when they signed up to put them in, and we've got a few. So I'll start with one of those just whilst we get a few more questions in. And it's to all of you really, but it's, how do you see the role of GP services evolving in light of the 10-year plan? Right. I'm aware it is a very difficult question. So does anyone have any thoughts on that? Yes.
I can't really comment on how they evolve, but one of the vital things with working with GPs is it needs, as it does with patients, needs to be done with and not done to. And lots of people don't understand that essentially the majority of GP practices are small businesses. They're funded in a completely different way, to hospitals. And unless that is considered and looked at, and GPs are brought along, they may also have the right to, dig their heels in. So just telling the GPs to do things isn't going to work. It's all about that co-design, bringing people along. They will know their people, their population better than anybody else. And they often need to be listened to an awful lot more than they are.
Jason, yes.
Yeah, I think what Zoe said in terms of the GPs that have been consulted, it also falls into the line into the Darren spoke about data silos, in that GPs should not evolve on their own. That there needs to be connection between GPs, the trusts, and the wider community of care providers. So there was a coordination between that. And as they evolve, there needs to be a sort of a common data transference, a sharing of information. This needs to be interconnected and not dealt with in silos, I think is what I would say is key.
Thank you. Yes. One from Christopher Smith Brown here that I think is really good. HSJ reported millions of patients being offered no choice provider when referred for secondary care tests. How can the independent sector overcome this as part of their role within the 10-year plan? Any buyers on that one? Again, quite a difficult question. Tom, yes.
I can talk briefly about patient choice. I think again, first of all, just to recognise that over 95% of our referrals don't come from GPs, which I didn't answer the previous question, but are choice-based referrals. So it's a critical part of the system in terms of whether it's around the flow of demand through systems, whether it's around making sure that the capacity and capability that's available across the system, the independent sector and NHS Trust. But I think that what we're seeing increasingly around patient choice is that choice isn't being made by or being informed by GPs, and in many cases not by optometrists in the community either. It's being made by some sort of referral management, triage, single point of access service. And I think that where those work well, actually, they're a really good way of enabling patient choice. Where they work well, they allow a patient to have a proper conversation about their choices, about what choice it is, and kind of takes that conversation away from a busy GP in their 8-minute appointment, or an optometrist who's just told a patient that they need to be referred in for cataract surgery or some other visual issue. So where they work really well, that's great. But where they don't work very well, they can sometimes be blockers, or they can not direct activity around the capability of providers. There's a lot of assumptions being made around those points. I think that what I would call for is that we have some actual models, some national models about what these look like when they work well, and try and share those out. I think we have 11 different referral routes, different systems and SPOAs and solutions that drive referrals into SpaMedica at the moment across the country. And I think not all of those work as well as some others, but there are some really good examples. Maybe it's something that HSJ and others could be thinking about around highlighting the best practice, but I do think that they work well when they work well.
Brilliant, thank you. I'm aware we are running out of time, so I've got sort of one more theoretical question. I was noted by the team for all of you actually, which is, what one change, if you could have anything you wanted, what one change in either policy or workforce or tech, funding or anything would have the single greatest impact on expanding out of hospital care over the next 10 years as we look at the plan? Chris?
I'm happy to jump in on that one, Theo. So, the 10-year plan sets out a huge ambition. This is transformation at a monumental scale. And it, obviously, there's a clear emphasis on the role of digital in moving some of these shifts. But of course, we know that this is not the first, attempt of the government to put technology at the heart of a transformed NHS. And in fact, you can go back to 1991, where the NHS published its first IM&T strategy, where it stated, staff will enter data once and share where needed. Information will be secure and confidential. And the NHS will share information using common standards in an NHS-wide network. So the ambition to do this has been there for some time. But thinking about the times that, I guess, government has achieved a major, reform, whether that's kind of implementing universal credit or responding to COVID or delivering the Olympics or launching the government digital service and creating gov.uk. All of those things, all of those major reforms required radically different ways of working. The rule book was like torn up basically to achieve those things. So when it comes to some of the brilliant points that have been made by my panelists, around funding, policy, commissioning, operating model change, the key thing I think is that we must be bold. So the thing I would want is a behavior change of boldness rather than anything else. And I think that will make the difference.
Brilliant. Thank you. Tom?
Yeah, I think that the one thing that I would think of is that it's that spirit of collaboration. A lot of the time, I think that the NHS commissioners kind of want to decide what they need and then go out to the market to fulfill that need. The problem with that, though, is it bypasses the opportunity for innovation. It bypasses the opportunity for partnership and collaboration. And at the start of this session, I mentioned the IHPN NHS England partnership agreement, which tries to build a framework around what that can look like. I think we've talked a lot today about trust, about relationships. I think that enabling those in some way would really be a game changer for the NHS, because it allows a proper conversation about what do we need, what is the capability that exists across the system to deliver against that need, and how can we best deliver that for patients. And of course, that's what we're all here for at the end of the day, is to deliver great services for patients.
Brilliant. Thank you. That is us at 11 at time. So does anyone else have any last closing thoughts on what's on their Christmas list for the 10-year plan? Zoe, yes.
Yeah, I'm going to go back to what I said at the start, and I was just having a look at the questions. There's an interesting one in there about physiotherapy. The funding follows the patient, so the patient can get what they need. So when they need health, it's NHS. When actually it's social care, that's what they're able to access. And following it that way, that would be my change. It's the funding follows the patient, so they can have what they need.
Fantastic. Thank you. Well, on that, I'll say to all of our panelists, thank you very much for joining us and for your genuinely insightful answers. We'll switch to this slide. The Out of Hospital Healthcare Conference, which we're running early next year, 11th of February in London, looking at what we've just discussed here, as well as slightly broader topics on exploring technology, exploring workforce, and many more. I'm running the agenda for that. You can see my email address down at the bottom there. If you'd like to speak at that, do drop me a line, and I'll try and get you on the agenda. I'm aware there are a lot of people with a lot of questions who I'd be very keen to hear their thoughts on. Tickets are available now. The agenda is being finalised. I hope to see you all there. Moving on from that, I'd like to say, again, a massive thank you to all of you, the attendees, for joining in and for your questions, and to, again, the panelists for your brilliant answers. Thank you very much.
Thanks all.
Thank you. Goodbye.
Thank you.